Welcome to the NIH World AIDS Day event. I'm Maureen Goodenow, and I'm the Director of the Office of AIDS Research at the NIH. And we are delighted at the turnout from across the NIH, and for all of you who are here today, we really appreciate your coming. Today is the 30th World AIDS Day commemoration. World AIDS Day started in December 1st, 1988, and it's a day for us to unite in the fight against HIV. To show support for the 1.1 million people living with HIV in the United States and the more than 37 million people living with HIV worldwide. And in addition, to remember the more than 35 million people who have died from AIDS or AIDS-related illnesses since the beginning of the epidemic. At this HIV and Beyond forum, we're highlighting the HIV research continues as the backbone for scientific discovery in the fight against HIV. It is well known that because of the substantial investment in and commitment to HIV research, NIH researchers have transformed HIV from a death sentence to a chronic condition, because with treatment, people living with HIV can have an almost normal life expectancy. NIH's annual $3 billion HIV research investment is by far the largest around the world, and together with community stakeholders and advocates and scientists within and outside the NIH, the course of research has led to many discoveries and breakthroughs that have essentially changed the face of the epidemic. So on this 30th World AIDS Day, thanks to the HIV research, much of it conducted by NIH-funded extramural programs as well as intramural investigators, and some of you are here in the room today. We now have antiretroviral therapies to manage HIV and to prevent transmission. There are a number of vaccine trials and monoclonal antibody trials for prevention that are underway. And because we know that treatment and prevention are not always readily usable by some populations, the research into novel delivery mechanisms, such as long-acting antiretrovirals, is really providing some amazing options. We're continuing scientific exploration towards a cure. And we're also proud of the HHS-wide collaboration in which NIH has participated to develop messages around U equals U, undetectable equals untransmissible. And we're looking forward to the official release of that message. OAR is the office that coordinates the HIV research investment across the NIH, providing funds to nearly every institute and center. Today, we're going to hear about some of the synergies of the HIV research funding and how the research investment has led to advances not only for HIV, but in many other areas of science, and how development in other disciplines has conversely contributed to our understanding of HIV. So we're delighted that you're here. I'm very happy now to introduce Dr. Gina Brown, who will be moderating our program. Dr. Brown joined the Office of AIDS Research as a medical officer in 2008, and we're delighted that she's going to take charge today.
So thank everybody for coming and taking time out of their really busy day. Just a few housekeeping issues. This is being recorded so that it will end up online. The other thing is there'll also be there'll be tweets coming from this talk, of these sets of talks, as people give us information. And the last is that I really want to thank all of our speakers for coming. They represent from across the course of all of NIH to really provide us with information and give us a sense of the depth and breadth of HIV research across the NIH, but also HIV's contributions. So the setup will be, we'll have 3 talks, have about 5 minutes for some clarifying questions. We'll go on to the last 2 talks, and then clarifying questions, and then we'll have an opportunity to involve the audience and really get a discussion going about the benefits of HIV research to the general population. My first speaker I'd like to introduce is Dr. Sarah Kattakuzhy. Dr. Kattakuzhy works with the DC Partnership for AIDS Progress, and that's a really wonderful collaboration between NIH, the Centers for AIDS Research, virtually all of the major medical centers in this general geographic area and the DC Department of Health. Dr. Kattakuzzy. And last to say, each speaker will have 10 minutes to speak. I'll show you 3 minutes and 1 minute. Thank you.
Hello, everyone. My name is Sarah Kattakuzzy, and as Dr. Brown mentioned, I am the co-director of an OAR-sponsored program, the DC Partnership for HIV/AIDS Progress, and specifically within that, the Hepatitis Clinical Research Program, which is a mouthful. So I want to thank Dr. Goodenow and Dr. Brown for inviting me today to speak on the intersection of HIV and hepatitis C. And specifically, I'd like to take a look at how the past, present, and future of hepatitis C has been paved by HIV research. So, as everyone in the room knows, hepatitis C and HIV both emerged in the second half of the 20th century, and their initial clinical description, isolation of the causal organism, development of the serum assay, and early therapeutics occupied much of the scientific community during the time period seen here, and continues today. And since then, successful combination antiviral therapy has achieved high levels of success, to the point where, specifically in hepatitis C, we now have multiple highly successful direct-acting antivirals, which can cure up to over 90% of the patients who take them in as little as 8 weeks, most of the time in one pill, once-a-day tablets. So while this achievement is remarkable and has already begun to save millions of lives, unfortunately, it's not the end of the story. Because while the availability of these safe and efficacious medicines are, in theory, true, most meta-analyses demonstrate that less than 10% of those infected with the virus have actually achieved cure. And obviously, these estimates are outside of closed systems such as the Veterans Administration and the Kaiser system, where medication utilization is higher. But indeed, for the majority of Americans and for most of the world, implementation of hepatitis C care has really fallen short of expectation. So in a world where you have medication with 90% efficacy that's only reaching 10% of its intended population, where does the field go from here? And so to find some potential answers, I think it's worth examining one of the greatest success stories of public health that Dr. Goodenow just eloquently described, which is the rapid scale-up of antiretroviral therapy on a global level for the treatment of HIV. And while HIV cure remains elusive, the implementation of this highly active antiretroviral therapy has saved millions of lives and will continue to do so. So it's worth looking at what enabled this successful campaign. So, as everyone here in this room knows, a cornerstone and foundation of this achievement was really the scientific advancements in HIV care. First, the idea that combination antiviral therapy, which remains the backbone of our care today. Next, rapid diagnostic testing, which allowed for expanded surveillance. And finally, a refined technical approach that was really based in simplicity, task shifting, and integrated care. Of course, HIV was a disease first identified within marginalized communities, such as MSM and persons who inject drugs, who were not just disenfranchised, but dying. And so another key factor in the implementation of HIV treatment was advocacy. And this was in the form of die-ins, as we see here, protests against the government. That's actually Rudy Giuliani and Bill Clinton. And speaking out in any opportunity and any forum available. And I think best exemplified by the angry urgency of ACT UP, HIV advocates forced a reckoning, which resulted in expanded therapeutic options, legal protections for HIV-infected individuals, and most elusively, government buy-in. And it was indeed buy-in in the form of the Ryan White Care Act as well as PEPFAR, that really allowed a holistic approach, an integrated approach that involved the government, community-based organizations, academic collaborators, all from the ground up, tackling this epidemic from every angle. And there are many other factors that I'm missing out, including the ability to adapt quickly to changing guidelines, really true grassroots level organization. But overall, I hope this encompasses that what the field of HIV research and implementation has accomplished in the last 35 years. So using that as our backbone, if we can look to the field of HIV, perhaps we can extend some of these lessons learned to understand how we get from 100% with chronic infection to 100% who've achieved cure. So looking at the scientific advancements, that's been one of the most exciting things in the last 3 to 4 years in the field of viral hepatitis, the development of direct-acting antivirals, which again have over 90% cure for patients. Rapid diagnostic testing is available for in the majority of the world, although point-of-care testing is still in development. Looking more closely at a technical approach, algorithm-based care is actually possible, thanks in part to the hcvguidelines.org website, which was established in part largely due to Dr. Mazur of the NIH Clinical Center. Studies looking at minimal lab monitoring and task shifting are emerging, including the NIH's own ASCEND investigation, which did demonstrate high rates of cure amongst patients treated by community-based non-specialist providers compared to specialist physicians. So what about the use of generics? Well, similar to the early days of HIV, when AZT was the most expensive medication, known at $10,000 per year, HCV medications are expensive. Here is a chart of whole acquisition costs for 1 day in the right-hand column. On the left, the various medications currently approved by the FDA. And they are expensive despite studies which suggest that the estimated production costs of these medications are a fraction of the WAC or whole acquisition costs. So generic medications do exist for hepatitis C through specific licensing agreements between pharmaceutical companies and certain countries. However, generics to date are only available in 61 mostly low-income countries, which encompass approximately a quarter of the HCV epidemic. Middle and high-income countries, including the United States, are currently excluded. Unlike the early days of HIV, community-based advocacy really is lacking in hepatitis C. And there were brief moments of unity, especially during the initial pricing of the first, second generation direct-acting agent called Sovaldi. However, the advocacy community really has yet to make a dent in the same manner as HIV. So obviously, one of the major considerations as to why this happens is the delayed serious outcomes of hepatitis C that really reduce the urgency of such a movement. But I would argue that an equally important aspect is the current landscape of unequal access to medications. So right now, older Americans who are insured through Medicare, as well as those with private insurance, for the most part are able to obtain hepatitis C therapy. Medicaid enrollees remain the main population with little or no access to hepatitis C medication. And by definition, Medicaid enrollees are poor and often disenfranchised, making advocacy on their behalf an even important goal. And here is another analysis recently published demonstrating the negative predictive value of having Medicaid on your likelihood of getting treated. Another, finally, perhaps in part due to the lack of community push, there's limited government investment in the field of hepatitis C, which takes many forms. So currently, most research funding is tied to subgroups of political interest, not to disease or implementation needs. With regard to price gouging of hepatitis C medications, there was a Senate Financing Committee investigation that actually concluded that Gilead priced Sovaldi to maximize revenue from this and future medications, but this really didn't lead to any change. And finally, there's Medicaid coverage, as we said, is limited. and has non-evidence-based restrictions. And finally, there's no PEPFAR or Ryan White CARE Act equivalent. There's no safety net for patients who do not have access to hepatitis C. So I'm going to fly through these conclusions, but where does the field go from here? Using the lessons from HIV research over the last 35 years, we can draw some conclusions. First, we should refine our technical approach through large-scale randomized implementation studies. We need to increase advocacy, especially within our marginalized populations, gain government buy-in, and finally, using this initiative, obtain access to low-cost medication so Hep C care can be implemented in a low-barrier, evidence-based manner following the path of HIV over the last 35 years. And with that, I'd like to thank you for your hopeful attention and time, and again, OAR for inviting me.
We're going to move on to the next speaker. Dr. Patrice Desvigne-Nickens is from the National Institutes of Heart, Lung, and Blood, where she's a medical officer working with arrhythmias and cardiac failure. And you'll find more in-depth views of their bios that came as handouts at when you first entered.
So I hope everyone can hear me. I certainly want to begin by thanking OAR for inviting me to this really important opportunity to review not just NHLBI, but progress in AIDS. So I just want to begin by talking about how NHLBI is navigating the present and charting our future with regards to our AIDS portfolio. So HIV is an evolving epidemic, and because of the effective, currently available antiretroviral therapy, patient survival has improved, but at the cost of an accelerated comorbidity or diseases. However, this accelerated disease or comorbidities serves as a natural bioreactor, providing perhaps new insights for therapy to prevent and treat disease. Research focused to improve outcomes for persons afflicted with HIV will provide insights for patients that do not have this disease. And I also want to acknowledge, because I think this is very important, the focused research that's made available through our AIDS overall program. The guidance and resources are really essential. And this has been a wonderful complement to the NHLBI portfolio. Again, I think that model of having when possible, a focused research area, setting priorities, but also making resources available to do this. It's a win-win, not just for the population at risk, but for the general population. Okay, so in this slide, I just wanted to highlight the many projects that are going on in heart, lung, and blood diseases. So we have 3 areas. And the projects vary. We have had a targeted program seeking investigations to elucidate basic research. The result of that is we have really exciting projects and some breakthroughs that are poster examples of good use of these AIDS resources. So we have not only preventive strategies for preventing vascular complications or vascular disease, but we have projects that look at the accelerated risk of myocardial infarction, or heart attacks, and investigations that have looked at understanding endogenous difference in platelet activity that does predispose to thrombotic outcomes. We have studies that are looking at lung disease. and HIV and its influence on inflammation and disease. So, as I said, we have a slew of research that's really very important. But for today's talk, I'm going to focus on cardiovascular disease. So in this slide, I wanted to underscore that among HIV-infected individuals, the median survival time after age 50 has increased from the late 90s from 11.8 or nearly 12 years in the late 90s to more than 22 years, nearly 23 years in the most recent decade. So a focus on heart disease also seems quite appropriate. As you can see in this slide, by 2030, it's predicted that 84% of HIV population will have more than one comorbidity. 28% will have over 3 comorbidities. But most importantly, 78% of patients will be diagnosed with CVD. And those patients will have a 30% higher risk than the general population. So we have insights in CVD by exploring CVD in HIV. So the Institute has had substantial success in addressing cardiovascular disease and reducing heart disease morbidity and mortality since the 1960s. So we understand control of risk factors, effective therapies for hypertension, diabetes, elevated LDL cholesterol, and healthy lifestyles. These are all the cornerstones of prevention and treatment, but it remains the tip of the iceberg. I think one of the important opportunities in addressing patients with HIV is the chronic immune activation, inflammation, and fibrosis that seems to complicate findings in heart disease. So heart disease is an enigma in cardiovascular medicine, and heart failure with preserved ejection fraction is a particular challenge. Researchers have recently postulated a key role for inflammation in the development of heart failure with preserved ejection fraction. Since patients with HIV have this chronic turned-on immune system from the time they're infected, it is likely that these, sorry, can you hear me now? So it's likely that that these patients will help in understanding the pathophysiology of heart failure with preserved ejection fraction. As mentioned, about half of the people living with HIV have heart failure, but the majority of those patients have heart failure with preserved ejection fraction. So I'd now like to turn to specific projects funded in NHLBI that are focused on heart disease. So the first study is a really incredible epidemiologic opportunity through the Kaiser registries and partnering with with the NHLBI cardiovascular research networks. This project will identify 39,000 HIV-infected patients with heart failure, and also age map with with 390,000 controls, that is non-HIV patients, to address 3 complementary aims that include to elucidate HIV and heart failure, and particularly the proportion that are ejection fraction, low ejection fraction, and preserved ejection fraction. But they'll also identify clinically meaningful treatments. And finally, the study will try to identify the effect of HIV status on heart failure hospitalization. Another study, which is part of the Heart Failure Clinical Trials Network, or CHART study, is a prospective cross-sectional study to elucidate the pathogenesis of diastolic dysfunction by comparison of patients with HIV and diastolic dysfunction to HIV-positive patients who do not have diastolic dysfunction. And then finally, we will also have as controlled non-HIV participants with diastolic dysfunction that have been identified in the MESA study. So in this very carefully planned cross-sectional cohort, participants have deep phenotyping with imaging, biomarkers, functional status, as well as characterization of their HIV status. A longitudinal follow-up is planned but not yet submitted. And finally, I'd like to underscore perhaps a what we expect to be a landmark study for HIV/AIDS patients, and that is the randomized trial to prevent vascular events, or the reprieve study. So this study, I'm happy to say, has really been a really outstanding collaboration with NIAID, as well as the AIDS Clinical Trials Group, and also with industry partners. But this study looks at the role of a statin, pitavastatin, to reduce major adverse cardiovascular events in patients with HIV who have a moderate atherosclerotic risk. The enrollment for this trial is about 6,500. We are actually over 5,000 patients, and we have over 130 sites actually now with international sites. But the results of this study will be so important in, for the first time, identifying a strategy, a drug, but also a strategy that may help reduce this elevated risk that are seen in HIV patients for with respect to heart events. Atherosclerotic events. And complementary is also a mechanistic sub-study, and this will look through advanced imaging techniques at the amount of calcification inside the coronary artery, and through both qualitative and quantitative techniques, we will understand whether the role of this statin is actually changing the progression of disease in the artery, in the coronary artery. So again, charting a future for HIV-related HLBS research. HIV is increasingly a chronic disease. Patients living with HRV are at high risk for other comorbidities, as well as heart-related diseases. And here we have this opportunity of using chronic immune activation to understand disease, and it may also be a model for understanding accelerated aging. Continued support of research on the health of people living with HIV, including leveraging extant cohorts, and supporting high-impact clinical and implementation science is possible. And these priorities are completely consistent with the NHLBI strategic vision. And I just also wanted to underscore that our strategic vision also aligns with the NIH priorities for HIV-related research. So with that, thank you so much.
Thank you, Dr. Desvigne-Nickens. Our next speaker is Dr. Diane Roush. She's the director of the HIV/AIDS research program in National Institutes of Mental Health, and she'll talk about that intersection of what we've learned using behavioral and social sciences research in HIV.
Okay, I want to say good morning and thank you for inviting me to give this talk. So I'm going to talk about the role of behavioral and social science in the HIV research and how it may impact in other areas of health. My goal is to talk a little bit about the behavioral and social science framework, and then I was asked to talk about two components that have a strong behavioral background that have an impact on HIV effectiveness for interventions, and then implications beyond HIV. So I want to start first with a brief overview of our behavioral and social science framework, and this was put together by Paul Gase and Mike Strout, which I think really defines the behavioral and social science that's important in AIDS research at this point in time. So they have defined 4 pillars. Basic behavioral and social science, which really identifies understanding vulnerable populations and the risks that they take. And then the elemental behavioral and social science research looks for targets for intervention and helps to develop them. The support of behavioral and social science research is probably most of the research community, the overall research community understands most, and that is the supportive, where the behavioral and social science helps to better strengthen the biomedical HIV product development and clinical trials to make them more acceptable and improve uptake and their usability. And then integrated behavioral and social science contributes to the implementation, and that is maximizing the impact of in putting these combination multi-level strategies together for maximum uptake and efficacy and effectiveness. So when we talk about HIV risk and care across the lifespan, we think about primarily individual factors that impact risk and care, but those individual factors are not alone. There's interpersonal, that includes parental monitoring for young people, partner interactions, family, peers, etc. And then you have the community, which provides either good or friendly or non-friendly access to services, condoms and PrEP availability, community awareness, and networks that can be targeted. And then there's also the socio-cultural, which is there cultural stigma? Are there policy and laws that have an impact? So these are all important components when we want to talk about targeting risk. So just to give a model for, these are the current behavioral and social science priorities within the AIDS epidemic. Because of our importance in our effective prevention and treatment strategies, the first key thing is to get into testing. If you're negative, you have to get into prevention care. If you're positive, you have to get into treatment. And these are life-changing events, because to stay negative, you have to continue to have these behavioral modification successes or take PrEP. And if you're infected, even if we get long-acting, there's adherence issues. In long-acting, taking a pill every day is different than taking a shot every month or taking an infusion once every 6 months or whatever. So there's adherence issues around all of these factors. And then there's a lot of psychosocial processes: mental health, depression, comorbidity, stigma, social support. These are all really important factors that are going to impact whether or not this gets done across key populations. And of course, there's these external factors also that can have an impact. So all of these things need to be addressed when we talk about intervening. So the first area that I was asked to talk about is stigma. Stigma is a perceived negative attribute that causes someone to devalue or think less of the whole person. And this is a prevailing negative attitude that certain societies or certain areas or certain populations put on other people. And these can be experienced where individuals feel the stigma. They can be perceived or anticipated so that they're going to behave so that they don't get stigmatized. And then there's internalized, where the person actually accepts the fact that whatever stigmatizing factor is out there, they have it, and so it's going to modify their behavior accordingly. And these can be barriers to testing, challenge to treatment initiation, interfere with retention and care, and can lead to increased morbidity and mortality. So I'm going to skip this for the sake of time. The components of stigma are multiple, and every one of these components is going to have an opportunity for targeting to improve stigma. There's stigma in the community, there's individual stigma, again, enacted, anticipated, or internalized. There's interpersonal factors, including stress, which can certainly be mediated by partner violence or violence in their environment, mental health, psychosocial factors, and these all affect engagement and care, which can then affect health outcomes. And these are all factors that can be intervened on with the goal of reducing stigma as a barrier to care and overall health outcomes. So we've known a lot about stigma, we've focused on it, but we don't really know how it works. And so this is just an example of the kind of behavioral and social science experiment that can be done to understand some of the mediators. And these investigators used the cohort from the Ys, to look at the mediating role of stigma isolation and depression. So if you have internalized stigma, they found that people that have stigma have decreased social support because they tend to not reach out to their friends or colleagues, and that can increase depression, and then this has an impact on adherence. So these are, even if you have good social support with internalized stigma, that may not be enough to increase adherence because a mediator could be depressive symptoms. So this is the kind of mechanistic study that we like to do that can identify targets for intervention and that can actually have a positive impact. And stigma beyond HIV, what have we learned? Because of the stigma research we've done, we've improved measurement and monitoring, which now allows us to estimate the prevalence and burden of stigma better. And if we understand the mechanisms and pathways, that we can develop interventions to target those pathways, and then we can identify barriers and develop strategies to reach the disenfranchised populations. So the next thing I want to talk about is social networks. We've known social networks are important for a long time. And social network, or a network of social interactions and personal relationships, they can be very powerful, but they're hard to define, and they can have an impact on the individuals within the social network if we can learn to define them and target them and use them. So I want to give an example. So social networks are hard to define because they're unbounded. So the only way you can identify a social network is you go to people and ask them who their friends are, who their contacts are. So this was a study that was done on runaway and homeless youth in California. There's over 2 million runaway youth and homeless individuals, young individuals in the United States every year. So, and we know that these individuals are at high risk for HIV infection as well as STIs. So what they did was they went into a health center that worked with these individuals and gave them behavioral questionnaires. And the key question from this study that I want to point out, it's a complicated study, but the key question was, when in the last 6 months, did you have condomless sex, or did you have sex with a condom or no sex? And the red shows that the individuals that had sex within the last 6 months without a condom, and you can see that there's a real concentration of high risk within the network. These are people who had some interaction with other people from the cohort, but they weren't necessarily involved within the network. And then so this was represented, within the network was about 75 of this 136. These are add up to about 25, and there were another 30 who had no connection with the network at all. So if you can define this network and understand it, then you can go in and ask, what can we do with it? So the next study was a pilot, the HOPE study. I'm almost done. The HOPE study, where they wanted to see, they did a randomized controlled trial both in the US and in Peru among young MSM, and they wanted to see if they could identify peer leaders and get these peer leaders through a Facebook intervention to increase their testing primarily through home testing or through adjacent clinics, and then get linked to care. And what they found was that both in the US as well as in the Peruvian population, they did increase 44% of the intervention group requested a self-help test compared to 20% of the control. In Peru, it was 17 versus 7. They found the more friends a participant made in the study, the more likely they were to test for HIV and go for follow-up results and participate in the group dynamics. And there was a high retention both at 12 weeks and 15-month follow-up. So this was just a small R34 pilot. This investigator now has an R01 to expand this, because if we can understand some of the dynamics around social networks, we can use them as a means for intervention. And so what we found out is that if we can expand our understanding beyond the individual into networks that can influence health behavior, we can use that understanding to identify characteristics and functions on behavioral health outcomes that can advance intervention development. And we can leverage social network approaches to identify ways to do this. So we put this model together that links both stigma and social networks. So we know social networks can convey attitudes, and those attitudes can be perceived within individuals within the network and have an effect on health outcomes. And it can be both through the anticipated stigma or the individualized stigma or experienced stigma. But these are all opportunities for interventions. We can go and look to see how can we work with the social networks to change attitudes and behaviors, and then this can trickle down to the individuals within the network, and we can have potential positive successes. And this is where a lot of work is being done right now. So with that, I thank you, and I really want to thank my team, particularly Andrew, Greg, and Susanna. Thank you.
We can take a few minutes now to open up for some clarifying questions for the three speakers who've already spoken. And please come to the mic in the middle.
Hello, good morning. I'm Petra Jacobs from NIDA, National Institute on Drug Abuse. So thanks for beautiful presentations from my sister agencies. I learned a lot, and I have a question for Dr. Kattakuzhy. And I was wondering if she can tell us a little bit more how to obtain access to generic medications to treat hepatitis C. What are the steps? Thank you.
Thank you. So it depends on where we're trying to get the access. So there was actually a wonderful study that was conducted looking at buyers clubs, the outcome of generic medication being imported from primarily India, which is where licensed generics are being produced for the most part, into Australia, England, and one other country that currently does not have generics. And the generics certainly do seem to hold up in terms of efficacy. Here in the United States, there is a restriction on the amount of imported medication that you can have. Interestingly, it appears to be about 3 months worth of medication, which for hepatitis C would be sufficient. And so my gut feeling is that in the next year to 2 years, unless things really change with medication access, we will be hearing more about buyers clubs within the United States. But that definitely is currently in place in other mid to high income countries throughout the world.
Thank you so much.
My question is also to Sarah. Specifically, as you go forward, we're kind of at a tough place. What do you think is the next big step we need to take to implement the care continuum for what we have, like with HIV? Is it access, or is it some demonstration projects that absolutely show what is feasible? What's your sense?
I think that number one, to close the largest missing chunk of the gap is actually in diagnosis. So to get people through the care continuum, they first need to know. So I think diagnosis is a huge missing chunk of where we need to go. But I also think what's very important is that what we've seen, the example that HIV has given us, is that simplified care through large demonstration projects give you the ammunition to enact change. And I think that is a huge missing component of hepatitis C as a field right now. And I think we need a large network of trials which demonstrate my belief that you can have very minimal monitoring because of the great safety profile of these medications. You don't need a lot of technology. You need a point of care test to see whether you have a viral load or not. And you need access to the medications. And it really can be delivered by pretty much anybody. And it will be successful. So I think that's what we need. Thank you.
Hi, Jack McAllister from the International AIDS Society. My question is for both Sarah and Diane. Sarah, you touched on it a little bit about the direction of research and problems with just the scale up of access to treatment having something to do with the divisions within those who are at risk of HCV. And I wanted to specifically call out sort of the divide in attention we see for people who use and inject drugs and those who do not. And I wanted to throw it to you, Diane, that in research on stigma, not necessarily associated with HIV, but for key populations, especially people who use and inject drugs, are there lessons we can be learned from the HIV research that we're not translating to hepatitis C research, but especially how we're understanding some of the gaps in access, both in the United States, I guess more in the United States, just given infection rates. But I wanted to see, if we could try to get a little conversation there going about stigma and how it relates to HCV and lessons from HIV, and just put people who inject drugs sort of on the table here.
So one thing is we'll also have more time for real discussion at the very end of all of the sessions, if we can get sort of a brief answer to these, and then we'll open that question up for additional discussion at the end.
I can answer from the hepatitis C perspective. Obviously, persons who inject drugs with substance use disorder, particularly opioid use disorder, are our target high-risk population. Estimates are very poor for many reasons, but up to 50 to 80% of those individuals will have hepatitis C. So whenever we talk about hepatitis C, that's a subgroup that's in the forefront of our mind. Stigma and access to that population is probably one of the toughest barriers to overcome. And I can tell you this because we're running a study in persons who inject drugs who are actively using drugs. These are people injecting on average 6 times a day within the last 2 days. So I can talk more about that study, but I think it's, I have personally seen how important the role of stigma is in that population.
I would agree that there are a lot of lessons learned from the HIV field that could be integrated into, particularly, I think, in the drug abuse population and the hepatitis C population. Again, capitalizing and leveraging the social networks that are there. If you can get people in there to change their sort of norms about how they think about themselves as well as others, then I think that there's a lot of opportunity to improve that. And then if you can improve it and it becomes cool to get treatment rather than stigmatized to get treatment, then it can happen.
I have quick questions for Dr. Nickens regarding heart, lung, and blood. With 40% or more of our new infections occurring in youth, particularly in individuals under the age of 30, which don't traditionally have a high cardiovascular risk, are we looking early enough, and are we dealing with the cardiovascular epidemic in the right way when reprieve and other studies are really focused more on the 50 and older age group? And how can we bring what we're learning in that population that we're intervening with now, bring that back to the younger age groups? And is there an initiative within Heart, Lung, and Blood to look at that?
Yeah. So thank you for your excellent but obviously difficult question to answer. And that is, so the as an example, the reprieve study, which is trying to demonstrate that reducing this by using a statin therapy that doesn't interfere with the antiviral therapy can reduce this excess risk. To be able to mount such a trial requires considerable resources. So in that group, the risk with for atherosclerotic risk really changes dramatically with age. And so under age 50, the risk is very, very low. And then if you're female and you don't smoke and other issues, make that very low, even though, as an example, women is a group that has doubled their risk. HIV-infected women have a doubling of their risk compared to non-HIV infected patients. So we know that it's there. It's not out of our sight. It's just very difficult to show you. It's really more of a preventive approach in this very low-risk population. So the resources needed are hard. If we are successful with something like reprieve, I think that will embolden us to take on, to take this a step further. And, in cardiovascular disease, we've been very successful, but the mortality and death rates and morbidity from cardiovascular disease remain primary across most populations worldwide. We have a long way to go, and obviously we are more about preventing risks than treating, treating risks and bringing them down. But again, I think that takes this shift that that requires resources and capabilities that I think with today's information technology and electronic transfer of health records, et cetera, makes these things more within reach.
Thank you. We're going to move on to the next two speakers. Dr. Nirali Shah is a research clinician at the Division of Pediatric Oncology at the National Cancer Institutes, and she'll talk about some of the exciting things that we've been seeing in the news lately with how HIV has influenced cancer treatment and management.
This and all. Well, thank you to OAR for the invitation to come speak today. So it truly is an exciting time in cancer therapy right now. And a lot of what has happened has really sort of taken advantage of understanding how HIV virus works and using that to optimize cancer therapies. I'll be focusing on one particular area of cancer therapy, and then we certainly would take questions in the discussion to talk about where we're going with this. I have no disclosures, and I hope to provide an overview of CAR therapy, which is chimeric antigen receptor therapy, review the current state of the art, and discuss some current limitations. So news, read all about it. 7-year-old the cancer girl cured by HIV virus. Revolutionary treatment uses HIV to reprogram cells into fighting cancer. An immune system trained to kill cancer. And how HIV became a cancer cure. So you have seen all of this, and I'm hoping to at least inform you about how we're using the HIV virus in the setting of immunotherapy. So what is a CAR? So CAR is a chimeric antigen receptor. Essentially what it does is that it involves taking a T cell and modifying the T cell by genetically introducing a receptor, so basically giving it a functionality of an antibody to recognize a specific antigen. So it takes the extracellular antigen binding domain and the intracellular signaling domain of a T cell, so it retains the functionality of a T cell with the antigen recognition properties of an antibody. I won't go into the different generations of a CAR T cell, but just talking about there are multiple generations of CAR T cells, all based on the co-stimulatory domain, so it involves how active it would be. In terms of making a CAR T cell, usually patients who have active leukemia will undergo a T cell collection by undergoing apheresis. Those T cells are then collected and undergo transfection using a modified virus. Either a retrovirus, or in particular lentivirus is being most used, which are particularly skilled, as you know, at entering T cells. These are then used to introduce genetic material into the T cell, which is then incorporated into the host genome. And then the modified virus is then used to introduce anti-leukemic targeted antigen recognition properties. So the T cells undergo then transfection. They then are given to the patient, which is after lymphodepleting chemotherapy. The T cells are then after given to the patient, they grow, they expand in the body, and they become effective fighting machines against the leukemia that expresses the antigen. And these are the current therapies that we're working on within the pediatric oncology branch. So the role for HIV is that this is essentially what we are using to introduce the genetic material into the T cell, which again really is using the anti-leukemia targeted antigen recognition properties. To give you a little bit of background on childhood acute lymphoblastic leukemia, so it is the most commonly diagnosed childhood cancer. There's about 2,900 cases per year. Childhood ALL really is a poster child for effective coordinated strategies to improve therapies over time. You can see here on this chart that over the eras, again, in the 60s and 70s, overall survival was dismal, and here's where we are now. So approximately 85 to 90% of children with childhood ALL will be cured, but what we're really focusing on is those patients who have primary refractory disease or those who have relapse disease where the outcomes remain pretty dismal. And outcomes, particularly in the adolescent young adult population, remain quite poor. So CD19 CAR. So what is CD19? It is a pan-B cell marker. The CD19 CAR is a CAR cell that was genetically modified to recognize CD19. It was first used to target CLL, which is an adult leukemia, chronic lymphocytic leukemia. It is associated with a constellation of symptoms, which is called cytokine release syndrome. So when the T cells go into the body, these T cells become activated, they grow and they expand, and they cause this constitutional symptom. And the first child with ALL was treated in 2012, and several centers had simultaneous clinical trials. To talk briefly about cytokine release syndrome, which is the most toxic part of this therapy, it is multi-system constitutional that includes neurologic toxicity that have included fatal neurotoxicity, includes hematologic toxicities, basically a whole body, hepatic toxicity, renal toxicity, pancytopenias, disseminated intravascular coagulation. It's sort of a modified sepsis, but not sepsis because it should not be treated exactly like sepsis. And there's various grades of cytokine release syndrome, including grade 1 through grade 4. All of this has really evolved in the past 5 years when we first learned how to implement CAR therapy and now how to make that CAR therapy more safe. So the clinical update. So this is the results from our clinical trial that we conducted in the pediatric oncology branch. Again, these are CAR T cells targeting CD19. We had a 67% complete remission rate. This is a phase 1 clinical trial. So just to give you a little bit of a background, typically for cancer therapies, we're looking at phase 1 trials really being for safety and looking at toxicity. We don't look at efficacy. Generally, the efficacy rates of phase 1 trials are less than 15%. So to be in an era where we're using, modified HIV virus to then lead to a phase 1 clinical trial that has a 70% complete remission rate is truly remarkable. This is our personal study, which was based on an intention to treat. So we took everybody and included them in our analysis, whether we were able to produce CAR T cells or not. This is a group at Children's Hospital Philadelphia that had a 90% complete remission rate. Again, these are patients who have failed all standard therapies. And then this is the basis for the global Novartis-sponsored trial that was called the Eliana trial, which had an 82% of patients achieving a complete remission, again, sort of the 65 to 70% based on an intention to treat model. And this is the basis for the first FDA approval. So just in this past year, just a few months ago, the first CAR T-cell therapy, which is based on the Children's Hospital Philadelphia CAR trial, is the first gene therapy to actually receive FDA approval. This is truly a landmark and truly groundbreaking in terms of cancer therapy and what we're doing. The next CAR therapy, also targeting CD19, was FDA approved just in August of this year, which is a certain type to target certain types of B-cell lymphoma. So the question is, will CD19 CAR be the answer? So this is Emma Whitehead. She is the first pediatric patient to ever receive CAR therapy. And I think has really been, again, now the poster child for how CAR therapy is. And the question is, will this be the answer? It's the first gene therapy that was approved. And I think the answer is not for everybody, but this is where the future is. So one of the problems with CD19-based CAR therapy is that there is antigen loss, meaning you can effectively target CD19 CAR. You can effectively target CD19, but leukemia tends to outsmart a single agent targeted therapy, which is not that dissimilar from, again, why we use multi-agent therapies to treat viruses, to treat bacteria, and also why we use multi-agent chemotherapy. So there's antigen loss, and about 30 to 40% of patients will evade CD19 CAR therapy because their leukemia will no longer express 19. There's CAR T-cell failure, so it could be that the CAR T-cells do not have persistence, or they don't work, or they go away over time, so that your leukemia may still retain the antigen, but you're no longer able to use the CAR T-cells. Inability to collect T-cells, so a lot of the data is based truly on those patients who have an adequate lymphocyte count for us to be able to do the lymphopoiesis. It does not include the proportion of patients who are so heavily beat up because of the therapies that we've given them thus far and cannot be collected. And then again, fatal neurotoxicity or cytokine release syndrome. So there is a lot that needs to be learned to really make this therapy safer and effective. I'll focus just very briefly on antigen loss, but again, I will say that at least at the NCI and globally, these are all areas that are actively being studied to improve the world of CAR therapy moving forward. So we developed at the NCI an anti-CD22 CAR. So like 1922 is another antigen that's expressed on leukemia. And at the branch, we have a little bit of a historical background in studying CD22 based on other therapies that we had developed. I won't go into details with this so much, but we just published our paper in Nature Medicine that showed that our CD22 CAR had similar efficacy to the CD19 CAR and was a salvage mechanism for patients who were CD19 negative and had failed, again, the CD19 CAR just as a result of relapse losing the antigen. But again, single agent targeting is not the answer. Relapse remains a problem. Shown here is a graph that shows you, again, this is the CD22 site density. On the y-axis, we have CD22 in a logarithmic scale at pre-treatment and at relapse. So either just decreased expression of CD22 or complete loss of expression is a problem for relapse after CAR therapy. So future direction. So what we're working on now is simultaneous multi-antigen targeting. We will be opening a trial hopefully later this year, by the beginning of the year, that will be both targeting 19 and 22 simultaneously. We want to expand to other disease subgroups and types. So we want to talk about AML, where there's a whole different set of issues to talk about targeted therapy. We have a cohort that will specifically be treating patients with CNS disease only, which were previously excluded in other trials. And we also want to focus a little bit more on lymphoma, where there are different challenges as it relates in comparison to leukemia. And then solid tumors and brain tumors, again, it's a completely different subset of cancer therapies where, CAR therapies have not been as effective. So it's really an approach to understanding what we can do, again, for these patients where chemotherapy is really not the answer. And again, we want to explore toxicity. So many people to acknowledge, but again, thank you all for the work you do, because I will say that these therapies would not be possible without HIV and understanding what the virus can do and how it's integrated into T cells.
Our last speaker is Dr. Jonah Odim, who's chief of the clinical transplant section of the transplant branch for National Institutes of Allergy and Infectious Diseases.
It was not too long ago that organ transplantation was viewed largely as an experimental science pursued by rogue cowboy surgeons out in the Ponderosa. And in parallel, the diagnosis of HIV was a curse, sure to render a quick and fatal outcome. Now, over the years, there's been quite a bit of progress that has been made since those days, and the progress has been remarkable. Organ transplantation is now an established therapy for folk with end organ disease. Meanwhile, in parallel, folk with HIV disease, that condition has been tamed with the advent of a combination of effective, safe, tolerable antiretroviral agents. But because of this success, we have a growing cohort of aging HIV patients with end organ disease that are now competing with uninfected HIV patients for a scarce organ on the national waiting list. Now, if you look at this graph, the steady rising black curve points to the number of people waiting on that list, up in the 120,000 per year. And the bottom lines are the relatively flat in blue number of donors that can provide organs per year, and in red, the red triangles, the number of actual transplants. And clearly you see the problem, the widening gap between supply and demand. In fact, every 10 minutes, somebody's being added to that list, waiting for an organ. And every day, 20 people are taken off that list because they die, because an organ didn't come about. Now, the scarce donor supply, in fact, has paved the way for the HOPE Act and the ability to do HIV positive to HIV positive transplants. And we'll talk briefly about how we got there, including the efforts that Peter Stock made with the NIH trial using uninfected organs in HIV positive kidney patients. The successes from that trial led Dr. Mueller in South Africa to perform HIV positive organs in HIV positive to HIV positive transplants. And in fact, necessity was the mother of invention in her country, since folk with HIV disease were not eligible for any other renal replacement therapy like dialysis. And the successes of these approaches led swiftly to the enactment of the HOPE Act a couple of years ago, which lifted the ban, 25-year ban of using these organs in patients. And that's spurned quite a bit of pilot studies in HIV positive transplants in this country, as well as a number of clinical trials that are on the launching pad and or within the pipeline here at NIAID. Now, historically, patients with HIV disease in most institutions in this country would not have received an organ for transplantation because it was felt that their lifespan was too short, and there was a presumed fear that the additional immunosuppression required with transplantation would unmask the HIV virus and accelerate AIDS. The Peter Stock NIAID-supported clinical trial over a decade proved this assumption wrong, as the results in patients with end-stage kidney and liver disease were actually quite good, certainly better than the national database of patients greater than 65 years of age, but slightly below in terms of graft and patient survival, all patients on the national registry. There was a cohort of patients in the liver pool, those with HCV infections, the co-infected patients who did not do very well. But of course, this was before the nice drugs that we heard about for HCV therapy that have emerged. Now, the HIV positive kidney transplant volume in this country is really taken off. And this is a volume that is a result of the use of HIV negative organs. And you can note on the x-axis around 2013, when the HOPE Act was passed, how the volume has really shot up as folk are trying to get experience with this approach to these patients. A similar, but not as robust, growth in HIV-positive liver transplants has also taken place in the U.S. Now, Elmi Mueller in South Africa has 3 or 4 reports in the literature of her outstanding experience and outcomes in kidney folk, patients with end-stage liver disease in her country, who all received HIV-positive organs because these patients couldn't be put on dialysis. And patient and graft survivals have been excellent. All the patients essentially have had excellent viral suppression after transplantation with relatively good urine and kidney function. And of course, with all these reports, there was a quick interest in using HIV positive organs in this country. And Dori Segev at Johns Hopkins, a surgeon, in this nice article chronicles the 3-year journey it took to get both houses of Congress in town on the side of the medical community, the transplant community, and the HIV community. And the HOPE Act was passed, but it limited the use of HIV-positive organs strictly in HIV-positive patients and within an IRB research protocol. Also, by that mandate, there was a requirement for safeguards as well as research criteria. And once those were in place, there have been a number of pilot HIV-positive to HIV-positive transplants performed over the last year and a half in this country, probably to the tune of about 30 to 32 cases, 20-plus cases in people with end-stage kidney disease, and the rest in livers. And while we don't have complete access to all the results by reports, most of those patients are doing very well. Now, there are a number of clinical trials that have recently been launched that are supported by NIAID, including an interventional trial using a commonly known HIV drug, Maraviroc, in patients with end-stage kidney disease, with the hope that we might be able to reduce the significantly higher rates of acute rejection in the HIV positive population. And Dori Segev at Hopkins with his partner Christine Duran are on the threshold of launching a prospective multi-center study clinical trial of HIV positive disease donor kidney transplants in HIV positive recipients. The companion liver study is a little upstream and pending scientific review. So HIV research has certainly made important contributions to organ transplantation in more ways than one, affecting the law, policy, regulation of how transplants happen in this country. We now have an opportunity for patients traditionally who have not had access to organs in this country. The research in HIV is opening and providing, I think, that access as we move forward. The HOPE Act does allow for living donation from folk who have HIV infection. And so it is impacting on ethics and how we think about it, informed consent issues, and a positive unintended or consequence of the pilot trial is that about 40% of the patients that were deemed HIV positive, that is the donors, turned out to be false positives. And so there is now a pool of organs that were traditionally, before the HOPE Act, excluded completely from the supply that is entering the pool. And of course, some of the mechanistic studies that the clinical trials are addressing include the issues of superinfection from the donor organ, issues of the latent HIV reservoir contained within the the HIV positive graft, as well as the alloimmune response. So in summary, advances in HIV research are yielding and will continue to provide dividends in organ transplantation, certainly at least at 3 levels. One, in the setting of negative, uninfected organs going into patients with HIV disease. now in the setting of HIV positive organs going into HIV positive recipients. And I think perhaps in the future, the use of HIV positive organs in HIV negative recipients following the hepatitis C story, where advances in hep C therapy make consideration of that choice a real consideration for somebody facing imminent death. I'll stop there, and I also want to thank my colleagues in DAIDS for longstanding collaboration with the transplantation section.
So we'll open it up first for a couple of clarifying questions for the last two speakers, and then we'll start a more general discussion, initially led by Gigi, who we wouldn't allow to ask a question at the end because we were running out of time. Any questions for the last two speakers?
Wonderful presentations. Thank you so much. I have a question for Dr. Shah and a question for Dr. Desvigne-Nickens afterwards. For implementation of the CAR therapy for cure approaches in HIV, it has been identified that the conditioning that you also had on the slide is one of the major hurdles. If you could kindly just discuss some of the approaches that have been considered or are being researched for CAR-19 and CAR-22 therapy. And the second question, the implementation of tumor xenografts for identification of novel antigens, in particular for solid tumors, and the tandem minigene approach for the same purpose of identification of tumor neoantigens would be critical. Are there any approaches of implementing this on a routine basis? And for Dr. Desvigne-Nickens, quick question on the role of exosomes in cardiovascular, in particular myocardial disease. At the recent extracellular communication, RNA communication meeting, there were studies shown that in the remodeling of the myocard, exosomes play a significant role. With using the CRE system, it was shown that the uptake of exosomes in the myocard correlated with a poorer outcome in the animal models. And my question would be, is there anything known about HIV animal models in respect to myocardial disease, or in more general terms, the role of exosomes, possibly also for the latent reservoir identification of cells that belong to that cell population?
So I'm going to ask you to briefly repeat your first question to Dr. Shah, just quick, so she can answer, and then kind of give you a brief, again, repeat for the others.
Conditioning advances and xenografts and other methods for novel antigens.
Oh, there you go. So in terms of the conditioning regimen, most of the regimens for CAR cell therapy right now are either a combination of fludarabine or cyclophosphamide, or given as a single therapy. They are lymphodepleting. I think various groups are using different strategies of higher dose, lower dose. I think probably a very general approach is sort of a 3 days of fludarabine, 1 day of cyclophosphamide. Our problem is, where we struggle right now, I think, with leukemia in particular, is that you also have a patient who has active disease progression while you're waiting for the CAR T cells to work. So even though the lymphodepletion doesn't have really good anti-leukemia properties, in some ways we are using that a little bit to buy time until the CAR cells become active, engaged, and can do what they need to do. So we've tried high-dose fludarabine and cyclophosphamide. We've tried low-dose fludarabine, cyclophosphamide. We haven't seen a huge difference in terms of efficacy of the CAR T cells. But I do think that that is going to vary from CAR to CAR, specifically as you cross the barrier between leukemia, lymphoma, and solid tumors. I don't think that there is, at least at this point in time, a set strategy that is absolutely going to be a uniform strategy for all CAR approaches, but will still require lymphodepletion. In terms of tumor antigens, so I think what makes leukemia particularly good is that, right, you have the leukemia, it's everywhere, and each one should have a relatively uniform distribution of antigens. But I will say that what we are learning in leukemia is that, and that will translate over to my answer to you in terms of solid tumors, is that even within leukemic populations, there is heterogeneity in antigen expression. So it used to be that we looked at, low expression, moderate expression, high expression, but at least what we're starting to do is actually sort of quantify that and look at the spread of expression. And so what I showed with regards to the CD22 is that, there is a threshold that you need to have a certain amount of antigen expression in order to activate your CAR. So you may end up treating a partial population that isn't as high expressing. And I think the problem with solid tumors is that there probably is a more heterogeneity in that regard. And in lymphoma, you probably don't know. So the biggest problem right now, I think, in terms of being able to figure out the antigens is that, in terms of biopsying, being able to sort of ethically do biopsies, you're not able to do that as regularly in lymphoma and solid tumors as they are in leukemias, right? Leukemia is a standard of care to do bone marrow biopsy probably on a monthly basis where you're able to do a surveillance, or they have circulating blasts. For lymphoma patients, you aren't able to look at that quite as well. So we did a lymphoma patient on CD19 CAR who then responded but then subsequently relapsed. We did do a biopsy at that time. It was clear that the 19 expression was lower. We then treated with 22 CAR, and then, again, had a nice response, but then emerged, and you could tell that there was an evolution of losing 19, losing 22. So I think what really has to happen is that you have to get a good sense of what antigens are available, and that becomes particularly challenging, just even in terms of getting those biopsy samples. And I think that there's evolution over time. So you may have the initial diagnostic sample. They've gotten so much chemotherapy by the time they come to immunotherapy that, to be able to get that sample, I think that becomes technically challenging in terms of doing good surveillance for looking at good antigens to target.
Thank you.
Your second question, briefly.
Yeah, I would have to refer you to a colleague to respond to your question. So if I could just meet after. But as I understand, you're asking about a change that would be that we would have information about due to antiretroviral therapy. Yes.
Yeah, it would be also a question about animal models.
Yes,
so the
and the animal
xenograft
model.
question and the question about the exosomes. This is currently not being used in vivo, obviously, because you cannot biopsy the myocard.
Yeah.
But it would be a potential sampling approach of getting access in the peripheral circulation to the same population of extracellular vesicles that can give you some information on pathogenesis, and would be a prospective marker that could be also used.
Yes.
But maybe we can continue afterwards.
Yeah.
Thank you.
Thank you.
Thank you. My name is Gigi Somerville. I'm from a neighbor from across the street at SAMHSA. I'm with the Center for Substance Abuse Treatment, and I oversee some of the MAI-funded programs. So I'm here at the invitation of Dr. Brown and Vanessa White, so I appreciate being here. I'm just looking at the many opportunities we have to collaborate with each other, because through our MAI funding in the Center for Substance Abuse Treatment, we fund substance use treatment providers, and they are required to provide HIV testing and hepatitis testing. So I think this is a big opportunity to, again, address the access issue. Here's a population that we have available for you. And then in turn, you can help us also with the education around hepatitis, because we find that same issue that people just don't realize the extent of the disease at this point. And of course, with mental health, we have our trauma-informed guidance and so on, which I'm sure you're familiar with. But again, the Center for for Mental Health Services has a whole pool of grantees that would be available to you for research possibilities. So I would like us to, start collaborating and looking at each other and how we can help each other, because I think in these days of limited funding, we can, really help each other a lot. Thank you.
So I have a couple of questions for the panel. One is for Dr. Nickens, and it'll be a similar question for Diane Roush, which is, can you define for us the kind of one single benefit of some of the work that's been done in HIV and cardiovascular disease and how that's benefited cardiovascular disease in general?
So one of the themes I tried to get across was this issue of activated, can you hear me? Activated immune system. So we've known about that inflammation does cause a, it has an effect on vascular cells, and actually as early as the 90s we found the pleiotropic effects of statin. So in a trial, Jupiter, we were able to show that patients who were well controlled, did not have other risks except for high inflammation, that reducing that inflammation did have a substantial reduction in cardiovascular events. So in HIV, where this is activated, this activation is from the time of infection, but it's much more accelerated, has been an opportunity. At this time, so we have two other approaches that are, as an example, looking at inflammation, and I think that they have been buoyed by the kinds of information that we have in HIV. So, thank you so much.
And then for Diane, can you talk a little bit about the tremendous work that's been done in networks that's been really informative, and how that will inform other areas outside of HIV?
The collaborative work that we've done in the networks in terms of...
What I mean is understanding the networks of HIV infection. Sorry.
Okay. So I guess I would talk about the intersection of mental health and HIV, and how certainly mental health has been a huge problem worldwide for many, many years. But now that it's such an important, it has such an important impact on treatment, on diagnosis and treatment and adherence, et cetera, that I think it's getting more visibility and broader than HIV. And we're finding that that there are a lot of opportunities to screen for mental health, both in HIV populations as well as in clinics, and deal with it. And I think that in some places that's changing community awareness about HIV, about mental health, so that people understand that there is opportunities for treatment. It's not something you just have to live with. And we have pockets of that happening. And I think that the work that we're pursuing in the HIV arena around mental health is having a much broader impact all over in non-HIV settings.
And a question for Jonah, can you talk a little bit about the follow-up of the donor patients who are part of this work for transplant?
Certainly. So far, the donor patients are all deceased, so they're not patients or human subjects. The HOPE Act does provide for living donation, and there are a number of teams in the country, I think 4 to 5, that actually have approval to conduct that through UNOS and have an open variance. But to my knowledge, a living donor has not been done yet.
And can you comment on the false positive HIV-infected donors, I believe?
With regards to the relatively high false positive rate, I think we probably should have anticipated that based on what the false positive rates are for the tests that are used out in the field for donor screening. And of course, if you're screening in 58 OPOs that cover the entire country, thousands of donors, and you have a 0.1% false positive rate for a test, you're going to get some false positives. The important thing to understand with transplantation is we don't have all day to check. you have a limited amount of time to work up the donor before the organs start to spoil, if you wish. So all those false positives were either positive antigen antibody, a negative NAT, or discordant. And then after the transplant, the confirming tests ruled it in or ruled it out.
I have a question also about the transplant from HIV donors. So my question is, in terms of the outcome of a transplant from an HIV positive donor, so how much is that a factor versus the comorbidities and the health status of the recipient? So how the outcome of these transplants from an HIV positive person differ from transplant that comes from an HIV negative donor, and if that is how big the HIV status is a factor in terms of the survival of the transplant and the survival of the recipient, regardless of the HIV status of the recipient.
Thanks for your question. I don't know that we have the answer to that question. I can tell you in the South African experience, they have the longest experience, although the epidemiology of HIV disease is very different, ART resistance and all those types of issues. But they've done probably about 40 patients over the last 8 years with excellent results. We, on the other hand, in the U.S., have probably done about 30 over the last 18 months within the HOPE Act. And those patients are doing very well, but it's much too early to know what the difference is between an HIV positive donor versus an HIV negative donor in an HIV positive recipient. Issues of superinfection, if there are different strains that you put in. We do know that, and this is from the French group, that when you put a negative organ into somebody that has HIV disease, they have seen in that graft post-transplant evidence of HIV in the podocytes and interstitium, despite normal renal function. So we don't really know what that means, and that is a little bit of a concern. When you speak with Elmi Mueller in South Africa, she has seen evidence in 2 of her 30 or so patients of HIV virus in the graft in the setting of fully suppression in the plasma. So perhaps we need to follow these patients much longer to really get an appreciation for the significance of that. But these are all excellent questions, and questions that investigators are trying to understand better.
Thank you.
I hope I answered a little bit of your question.
Yeah, I mean, we have still a limited number of transplants in
That's correct.
From these donors. Okay, thank you.
Yeah.
I just had a question for Dr. Shah. Since you need a certain number of T cells to do these CAR therapies, do you ever foresee that HIV positive patients that, for example, develop lymphomas, are they going to be able to be treated using this type of therapy?
We're getting better and better at collecting cells from patients who have very low numbers, and also using different cell processing techniques to sort of optimize that. I think the other thing that will also change is that you'll probably be collecting T cells from patients who are earlier in their disease. So I think there's just so many variabilities to know how that will all unfold. But I think, the field is evolving, so I think it would probably be possible at some point.
For Sarah, you've done your group has done some interesting work getting particularly hard to treat patients, both dual infected and mono infected with hepatitis C. Can you talk a little bit about how you've gotten them to treatment and gotten them to cure?
Sure. I think the overall theme is you need to meet patients where they are. And so Dr. Mazur established at the time that the DC Partnership for HIV/AIDS Progress was being established. It was done so with a lot of community involvement and investment within the Washington, D.C. community. And from its inception, DC PFAP for short, had collaborative partners who were based in community health centers. And so that, I think, is the foundation for how we're able to quickly and efficiently recruit for our studies and bring research to a population that was typically very skeptical of research to wide acceptability and bring novel therapies to a population that would not otherwise have access to such medications. So I think meeting patients where they are is how we were able to do that. And by that, I mean we established at first clinical care as NIH providers within these clinics, and then subsequently the next phase was recruiting for studies within those clinics, and then finally we brought the actual studies to the clinics themselves.
It's a question for each of the speakers, which is if you had unlimited funding or as much funding as you could possibly need, and you had other resources, one, with what groups would you collaborate? And two, what would be the work that you would want to do? We can start, anybody who's up for that first? I'm going to call on you.
Hopefully I alluded to it at the end of the presentation, and Dr. Diefenbach asked me this question, but I think there is pretty limited funding for hepatitis C as a monoinfection, particularly with regard to implementation science, and I think that is where the field needs to go. So I would establish a network similar to HPTN make it multi-institutional throughout the world so that we encompass all genotypes in different care settings and have a large trial of minimal monitoring, perhaps even field-delivered medication treatment. And I think that some of that money I would also use to rope in community-based advocacy organizations and also partner with organizations and institutions that are studying how we can retain patients in the long term and keep them from hep C reinfection. So that also includes activities such as, addressing concomitant opioid use disorder, high-risk sexual behavior, and so behavioral modification, treatment of opioid use disorder would be important questions for hepatitis C.
So while implementation science is really important and that is a priority, I am impressed with the opportunity to partner with infectious disease, cancer, and our cardiovascular researchers. So we have drugs that the antiviral drugs that have an effect on heart CVD outcomes, and we need to understand these things better. I would really like to see a kind of center approach that included these disciplines and focused on drugs, repurposing drugs, and understanding that. But I think there's a tremendous opportunity.
I have a lot of priorities that I can articulate, but in the spirit of today, I would say that I think that given what we know about our goals to get to 90-90-90 worldwide, and the incredible burden of mental health issues, particularly depression, getting people into care and on treatment and adherent, And there's a lot of work being done at the ground level worldwide. There's increasing awareness. There's screening that's being done without treatment. And I think that if we could expand the collaboration between the mental health and the AIDS 90/90 goals, that we could actually make a lot of progress. There's a lot of violence. There's a lot of that has an impact. It impacts women in sub-Saharan Africa. It impacts minorities here. So I think if we could address some of the mental health issues, that we could probably make some progress.
So due to time constraints, I did not talk about the price point of these new FDA-approved therapies, which you probably have heard about, but they're about $500,000. And it is not easily available. If you don't have insurance, it's almost impossible to get these therapies, not to mention that to try to get this somewhere else in other countries, it's almost nearly impossible. So I think what needs to happen in the world of CAR therapy is to be able to find a way to make this more affordable, more accessible, and more widely available in a global setting. We at the NCI have partnered with a group in India where they're trying to start CAR therapy there. Europe is definitely starting their own CAR therapies here, but I think what really needs to happen is to be able to bring this therapy down to a price point that is affordable. The other thing that I did not get to mention much about in terms of just leukemia therapy, specifically ALL, AML, is that bone marrow transplantation still plays a very crucial role. And so what is evolving in the field of CAR therapy is whether CAR therapy will truly be curative or just lead to remissions, of sort of what the durability of that is. Bone marrow transplantation in and of itself also has a price point of about $500,000. And so I think sort of what needs to happen in the field is understanding the role of CAR therapy in leukemia treatment overall, whether that will offset some of the costs down the road or replace some of the other therapies. I think that's where the future is.
Well, I'll just focus on what I think are some of the immediate issues with the critical organ shortage, which has been in existence for 3 decades in this country. When you look at hepatitis C positive organs, we discard nationally about 1,000 of these a year, simply because once they have been recovered and placed in hepatitis C positive patients, there are no other patients to put them in. So that is a waste of organs, and each donor can provide organs for 8 recipients. With regards to HIV positive organs, it's really unclear how many we have in the country, simply because their rules, state laws differ. Who has AIDS, who has HIV, what you can report. So nobody really has an accurate assessment of how many potential HIV deceased donors there would be. There have been predictions based on a couple of reports, anywhere between 200 to 500 donors per year. But if you look at the number of donors that have been recovered over the last 18 months, it's about 20. So it's almost less than a donor a month, and this is throughout the entire country. So there are some other issues that are playing and factoring in to what's going on. By law, all hospitals have to report imminent death to OPOs. There are 58 of them that are assigned throughout the country. And then these OPOs have to examine for the potential for transplant these folk in hospitals. They may be different incentives that OPOs have with regards whether they will go out on a referral to procure organs. They are graded by the yield of organs they get per donor. The average is about 3.5 nationally. So if you can get 8 organs, and the OPOs are averaging about 3.5, right now the HOPE Act only allows you to use kidneys and livers. Some OPOs that may not have other revenue streams may find working up a donor just to get 1 organ may not be in their best interest. And so there are a number of things that I guess if I had some money to do some studies to try and pinpoint where things fall, because capturing these donors and their organs would make a big impact, given the fact that the transplant community, ever since the emergence of this technique for folk with end-stage disease, have faced critical shortages for the last 30 years. So that's where I would begin, sort of address some of the immediate issues, and of course with the curative drug therapies for hep CV, you can begin to imagine the possibilities, and one can think with improved preemptive, prophylactic, and curative, perhaps vaccines for HIV, one can also begin to think about the possibilities for organ transplantation. Thanks.
So I was going to address things more generally than specific questions to the panelists. I'm Stuart Shapiro in the Division of AIDS, and I'm a baby boomer, and so I grew up with the race to the moon. And I remember back in the 1960s, a lot of people saying, you know, this is a waste of our money. We have so many problems at home that we could be spending this money on, that going to the moon is a total waste. Well, those people don't realize that going to the moon, the funds that were invested in that, they drove the development of a generation of computers. They drove the development of a generation of microcircuitry that has had profound impacts on our society and internationally, globally, on technological development. So there was this was not a trickle-down benefit to everybody else. This was an amazing benefit, the amount of money that was spent on the moonshot. Well, the lesson there that I take is that any time society takes on a major scientific challenge, there are remarkable benefits outside the original narrowly defined goal. And HIV/AIDS is similarly a formidable scientific challenge, and it has been well-resourced. But it's been well-resourced because of the urgency and the anger of the people that were getting infected with this disease. That got us the resources. The resources have resulted in just a remarkable, a dazzling amount of progress. The amount of the detail with which we understand this disease today in such a short period of time has been amazing, and it has proceeded in lockstep with other advances in biomedical science, and in some cases driven those advances. So there has been a remarkable impact on a lot of the rest of medicine because of the money that was spent, even though all along we had people who were also saying, because they had other diseases that they were mostly concerned with, that this was a waste putting so much money into this one disease. However, and I think everybody in this room would agree that it has not been a waste. However, we are possibly going to become a victim of our own success. Now that AIDS is considered a chronic disease by many people, there's no longer a sense of urgency or anger, and this is going to impact our funding. We have to make the case, all of us in this room, all of us working on AIDS, have to make the case for the remarkable benefits to the rest of medical science, and not just the rest of medical science, the rest of society from what we do. And I hope that this World AIDS Day Symposium is only the start of this effort.
Thank you, Stuart. No additional questions. We'll close with some comments from Dr. Goodenow.
Well, if I can paraphrase Jonah, wow, what a great session. This has just been a fantastic morning. I hope you've all enjoyed it as much as we have. I'd like to thank you all for coming and for staying. And I'd also like to acknowledge the team from OAR who coordinated this event, and certainly in combination and partnership with folks across the NIH and even beyond. We're really happy that SAMHSA people are here, that IAS is represented. I don't know who else is on the line, but I know that there's, this really represents, I think, the trans NIH and beyond footprint that these events can have. Just a couple of observations, not to keep you here too much longer, but I think in sort of summing up this, one of the themes that came through to me was the impact that all of the research that was talked about and all the research that we didn't have time to include today really has across the whole research continuum, from very, very basic in the lab, wet bench type of research all the way through the impact it has on public health, and not only at the community level, but also internationally, and the outcomes for, in some cases, I see as our ultimate consumer, and that's the PEPFAR program that interdigitates with really looking at everything that comes out of our pipeline at the NIH side. And so I also see today that we heard a lot of themes that I'm very excited about the new approaches to answering fundamental scientific questions, and where we can see going forward opportunities for synergies, not only for HIV going and helping other areas, but the feedback loop of what we can learn as we, for example, develop cure strategies. The challenge of having something that will work in different areas but may not be implementable or taken up very well by the community, which would be something we can start to be prospective about. The other thing that I heard too was if all of the speakers really had a policy theme and policy outcomes from these researches, the new FDA approvals, the changes in legislation that allows for different practices. And I think that's an aspect of research that we don't often think about, but that's really in some ways where we want to go. And then also too, there was a universal theme that I heard about the issue of equity, justice, and stigma. And I think in all the cases, this is an area that we really need to learn across all the research enterprises. It doesn't matter what the specific disease is, but how can we learn across the communities. So I want to thank again the 5 colleagues from the 5 different ICs. I want to iterate that we know that across 27 ICs, there is a lot more research going on, and we thought, though, having a 2-day symposium was probably a bit too much to be able to cover all of that. But we'll be looking forward to continuing this theme as we go forward. So thank you again for coming, and enjoy the rest of the day, and have a great weekend.